Welcome, everyone. To begin our session, we must precisely define our subject. Clinically, we are looking at a syndrome, a constellation of features, driven by a singular biochemical reality: the presence of excessive circulating levels of thyroid hormones, specifically triiodothyronine, T3, and thyroxine, T4. This hormonal surplus triggers what we call a hypermetabolic state. You can think of this as the body's internal engine being turned up to a pathological degree. Because almost every tissue in the human body is sensitive to thyroid hormones, when T3 and T4 levels exceed the physiological norm, the baseline metabolic rate accelerates significantly. In short, our definition hinges on this metabolic overdrive. It is the systemic response to that hormonal excess that defines the clinical picture. Let's keep this physiological foundation of a hypermetabolic state driven by elevated T3 and T4 in mind as we move forward. Moving to etiology and pathophysiology, we must distinguish the why and how behind thyrotoxicosis. Etiologically, causes often follow demographic patterns. Graves' disease is the most common cause overall, particularly in younger patients. In contrast, toxic multinodular goitre is the frequent culprit in the elderly. Other causes include solitary toxic adenoma, post-viral de Quervain's thyroiditis, postpartum thyroiditis, and cases induced by the medication amiodarone. Pathophysiologically, these conditions operate through three distinct mechanisms. Graves' is an autoimmune process where TSH receptor antibodies, or TRAb, directly stimulate the gland. Toxic nodules, however, involve autonomous hormone production, bypassing normal regulatory loops. Finally, in thyroiditis, the mechanism isn't new synthesis at all. Instead, follicular destruction leads to the sudden release of preformed hormone into the circulation. Distinguishing between this leakage and true overproduction is central to your clinical understanding of these diseases. When we approach the clinical diagnosis of thyrotoxicosis, think of a body running in overdrive. Patients typically present with heat intolerance and excessive sweating, paired with the classic paradox of significant weight loss despite an increased appetite. On examination, look for a fine tremor and signs of anxiety. From a cardiovascular standpoint, palpitations are common, and you must be particularly vigilant for atrial fibrillation, especially in older patients. You may also observe lid lag and lid retraction, giving the patient a startled appearance, or proximal myopathy, where the patient struggles to stand from a seated position. Finally, we look for signs specific to Graves' disease. This includes exophthalmos, or bulging of the eyes, pretibial myxoedema, which is a localized skin thickening over the shins, and thyroid acropathy, a form of digital clubbing. Recognizing these specific features is key to confirming the underlying etiology. Now let's focus on the diagnostic criteria and the essential differential workup for thyrotoxicosis. Our starting point is always the biochemistry. We are looking for a suppressed TSH, characteristically less than 0.01 millunits per liter, alongside elevated free T4, T3, or both. Once thyrotoxicosis is confirmed, we must identify the underlying cause. Detecting TSH receptor antibodies, or TRAb, provides a definitive diagnosis for Graves' disease. However, if a technetium scan reveals reduced isotope uptake, this shifts our suspicion away from hyperthyroidism toward either thyroiditis or factitious hormone intake. Finally, clinical context is key. In a patient presenting with a painful goiter, significantly elevated inflammatory markers, such as ESR or CRP, are highly suggestive of de Quervain's thyroiditis. By synthesizing these biochemical, serological, and imaging findings, we can accurately differentiate the various etiologies of thyrotoxicosis. Moving on to investigations. Our first-line approach begins with thyroid function tests, specifically TSH, free T4, and free T3, to confirm the biochemical state. However, it is clinically vital to obtain a baseline full blood count and liver function tests before initiating medical therapy. We require these because carbimazole can cause agranulocytosis, and both carbimazole and PTU carry risks of hepatotoxicity. We must know the patient's baseline. To determine the exact etiology, our gold standard is the technetium 99M pertechnetate uptake scan, which clarifies the underlying cause of the overactivity. We support this with antibody testing, looking for TSH receptor antibodies and TPO antibodies. Finally, never overlook systemic complications. An ECG is mandatory to screen for atrial fibrillation. If your physical examination reveals any nodules, a thyroid ultrasound is the appropriate next step to assess structural abnormalities. Together, these investigations provide a complete diagnostic picture. When managing thyrotoxicosis, we prioritize immediate symptomatic relief using beta blockers, like propranolol, to control tachycardia and tremors. Our primary medical intervention is carbimazole, typically continued for 12 to 18 months in Graves' disease using either titration or block-and-replace regimens. If carbimazole is poorly tolerated or during the first trimester of pregnancy, propylthiouracil is our preferred alternative. For definitive treatment of toxic multinodular goiters or relapsed Graves', we utilize radioactive iodine, though it is strictly contraindicated in pregnancy and active eye disease. Surgery remains indicated for large compressive goiters or suspected malignancy. Finally, we must recognize Thyroid Storm as a medical emergency requiring ICU care. We use high-dose PTU to inhibit both hormone synthesis and peripheral conversion, followed by Lugol's iodine at least 1 hour later to block hormone release. Comprehensive supportive care includes intravenous fluids, cooling blankets, hydrocortisone, and intravenous propranolol for rapid rate control. Let's consolidate these high-yield MRCP pearls. First, safety. Always counsel patients starting carbimazole regarding agranulocytosis. If they develop a sore throat or fever, they must stop the medication immediately and seek an urgent white cell count. In pregnancy, timing is critical. Use propylthiouracil in the first trimester to avoid carbimazole-linked aplasia cutis, then switch to carbimazole for the remainder of the pregnancy to mitigate PTU's risk of severe liver failure. Regarding Graves' ophthalmopathy, remember that radioiodine can exacerbate eye disease. Notably, smoking is the strongest modifiable risk factor for progression. If you encounter a painful goiter with high inflammatory markers, think diclofenac. Use NSAIDs or steroids. Antithyroid drugs are ineffective here. Similarly, for amiodarone-induced thyrotoxicosis, distinguish type 1 iodine excess treated with antithyroid drugs from type 2 destructive thyroiditis, which requires steroids. Finally, treat subclinical hyperthyroidism if TSH is below 0.1 and the patient is over 65 or at risk for AF or osteoporosis. And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at mrcpelite.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests. One for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year. a significant saving from the standard price of $250. So, head to MRCPELITE.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.